All right, joining me now here on the Matthew Filipowicz Show is Tracy Weitz. Tracy is an associate professor and the director of the Advancing New Standards in Reproductive Health program at the University of California, San Francisco, which you can find at ANSIRH, which is ANSIRH.com. You can also find her on Twitter at Tracy Weitz. Tracy, thank you so much for being on the show.
Thank you for having me.
All right, so Tracy, we recently had the 40th anniversary of the Roe versus Wade decision, but your program, ANSIRH, actually did a really interesting study when it comes to abortion. Why don't you tell us all about it?
Sure. So Roe was legalized in 1973, which was 40 years ago, and since then, abortion technology has improved, healthcare has improved. We have advances such as ultrasound and early pregnancy testing. So we were interested in the question about whether nurse practitioners, physicians' assistants, or midwives could perform abortions with the same safety profile that their physicians' colleagues did. There were two small studies that had been in the published literature that suggested that it was true for physicians' assistants. There's been some international work done on nurses. So we were interested in California about what that would look like. We did a 5-year study. Nurse practitioners, physicians, assistants, and midwives completed over 5,000 procedures, and they had a comparative group from physicians of about the same number, and we found no differences in safety outcomes across the two groups.
And so, again, it's pretty, the procedure itself is not something that necessarily requires a physician to do. And it's something that, because of this, it actually kind of shows that in places that may not have access to a physician, or so, it actually could lower costs, but also broaden access nationwide potentially, correct?
Yeah, I mean, expanding the pool of healthcare providers for all kinds of primary care services is a trend in healthcare. The Affordable Care Act is going to, increase the demand on the healthcare system to use the right type of clinician to offer the right type of services. What we know is that early abortion is safe, and it's safest when it's done earlier. So if patients can get that service from the healthcare provider that they're already seeing and not have to do a referral, drive to another place, drive to another city, and in particular, women of reproductive age who are relatively healthy are more likely to see nurse practitioners, physicians, assistants, and midwives for their general health care. So they're already seeing these clinicians, and we believe that increasing that, a point of access will both expand general access to care, which is good for women, but also potentially reduce the delay factor associated with obtaining an abortion for many low-income and typically isolated women.
Yeah, you write in the study about how in California there's a percentage of women using Medicaid, and that this could actually seriously help them along in that regard.
Yeah, nationwide, about 90% of abortions, or over 90% of abortions, are done in the first trimester. But in California, 13% of the abortions are done after the first trimester for women using public assistance. So we think about that as a healthcare disparity issue. One potential target is to make sure that those patients can get access to earlier abortions. They tend to be more likely to be served in either family planning clinics or community health centers. Those are both places predominantly staffed by nurse practitioners, physicians, assistants, or midwives.
And this is also something that not only, but it's also happened in 4 other states. Non-physicians are allowed to actually perform these type of abortions.
In 3 states, New Hampshire, Vermont, and Oregon, there was never a restriction placed on who could do an abortion. It was always whether you were appropriately licensed and appropriately trained. So in those 3 states, these clinicians have been doing services since 1973. In Montana, there was an effort to restrict a physician assistant who was doing abortions, and the Montana State Supreme Court said you can't restrict a woman's access to care unless you have a good reason. And since there was no difference at that time in the outcomes between that physician assistant and her physician colleagues, then there was no reason for that restriction. So 4 states allow that. 2 states, there's not a physician-only law. That would be West Virginia and Kansas, but they have very restrictive abortion laws or healthcare regulation in other kinds of ways. And so nobody has tested whether or not those clinicians could do services in those states. In all the other states, there's either a requirement that it be done by a physician, or what we've seen as a trend in the last few years is states specifically passing legislation to prohibit non-physician clinicians from doing services.
And that is clearly a tactic used to try to actually limit the access of reproductive care to women, obviously.
Yeah, it's part of a larger trend in abortion regulation generally, which was after the Supreme Court in Casey said you can't ban abortion, but you can restrict it for almost any reason. States began to pass whatever law they could that they thought was going to reduce access to care. And you're seeing, the impact of this. There's been a lot of attention to it in the Roe discussions about the 4 states that only have one abortion provider. The very overt statements from governors like Governor Perry, who say his goal is to make sure that Texas is abortion-free. In Arizona, where they passed a law to prohibit nurse practitioners, they said very specifically it was because they wanted to restrict the availability of abortion.
And again, like your study showed, as very an intense study that actually that nurse practitioners and midwives and physician assistants can actually provide this procedure, and it actually does not affect the success rate of the procedure. It does not affect the actual health of the woman who is receiving it.
Yeah, what I like to say is to remind people that abortion is a socially complicated question. It has many philosophical and ethical issues that people are concerned about. But as a medical matter, early abortion is very safe. And we've conflated the two and tried to address the social complexity by regulating it as complicated health care when it is not.
And that's pretty clearly, again, a PR tactic and a I guess how to say, a legislative tactic to try to conflate that. And the fact is, I guess, those who believe in a woman's right to reproductive health and to the right to have access to it have we missed that side of this argument and the fact that we allowed it to get conflated in this regard?
Yeah. Many genuine people wanted to think that there was a compromise about abortion, that we could allow some forms of restriction, that would sort of show the social disapproval of abortion and would still allow women to have access. And I think many good-meaning people who support the woman's right to have to reproductive services said, okay, well, this seems reasonable. This seems like a good social compromise. Not thinking about the impact of this and how it would affect different populations differently, so women who don't have access to money or who are located far from an abortion provider. And what it didn't do was stop the abortion wars. They continued to accelerate, and these restrictions, rather than sort of being compromises, turned out to just be the start of the snowball. And now we're seeing things that even sort of moderates on abortion are saying, okay, this has gone too far. You have pushed it so far that now it's in the realm of the ridiculous. We did this study because while we thought that it was probably true that these clinicians could do this procedure safely, as it's a very low-risk procedure, we still believe that evidence should drive public policy around abortion. And so the studies that were in the published literature were suggestive of safety, but they weren't large enough to really be able to say anything. So we did the study to be able to answer that question definitively. Sometimes both advocates in favor of abortion rights and advocates against abortion rights just argue at the ideological level and forget that we really should do good quality science. We should make policy based on good quality science, and that there's an obligation of scientists to participate in this highly contested arena, even though results get blown up out of proportion, people get threatened. It's still really important that science inform healthcare regulation, not ideology.